Agnihotri sir, Ramakrishnan sir, Nehal Patel, Atul Heda, and Rupali Tiwari. I was the moderator for it, and the panelists were right from senior people, faculty who had established the milk banks. Some like Dr. Agnihotri, who have been very actively involved with all IAP activities, IYCF, as well as people who were outside helping with the Human Milk Bank and IYCF chapters. And right till the youngest one who is actually doing her DNB. So we wanted a perspective from all of them at various levels of their pediatric experiences as to what the future of the practice could be. As we all know that 27th November is celebrated Human Milk Banking Day in honor of our first human milk bank that was established in Asia by none other than Dr. Armida Fernandez, madam, and it was at Sion Hospital in Mumbai. And in 2024, 34 years down the line, we are there now, and we wanted to see how many milk banks we have. Now, if you look at this picture of the map of India, there are around 120 human milk banks, and there is a separate Human Milk Banking Association of India organization, which is which helps activities of IYCF also, and there are around 130 members. Just to give a background to the panel discussion, I had put a few things together that majority of the milk banks in India today are established government funded only in the central government places. Medical colleges, government and private sectors, private hospitals, corporate hospitals, they do have human milk banks based on their workload of neonatal babies who are admitted, the delivery rates, etc. Majority of them are standalone, as against you go abroad to Brazil, Europe, America. They have a network of human milk banks, and the milk is pasteurized and shared with the separate NICUs. In Rajasthan, we have many human milk donation camps which are there. In BJ, we have the first human milk collection van which goes out in the community. And as of the guidelines, if you look at human milk bank establishment and sort of functioning, we have 2017 guidelines which are there. These are national guidelines. And to see whether the quality of these are maintained, in 2021, Ministry of Health and Family Welfare came out with these guidelines. Of course, we know about the IMS Act, and that was again amended by 2003 amendment. And then we have these association and IYCF chapters which deal with these issues of human milk banking. So the questions which I will just run through, and then we will come to what the take-home message was from. So the questions that were posed like, are these human milk banks really helpful, or they are a hindrance to breastfeeding practices, and also do they hinder with the care of very low birth weight babies or ELBWs in the NICUs? If considered a benefit, then how do you see 10 years down the line? What will be the picture of human milk banks in India? Then is it a successful option for newborns who need human milk feeding and we don't want to give formula feeds? Is having a human milk bank a best option? The other one, if you feel that it is hindering the breastfeeding rates which happen in the hospital or in the NICUs, then what are the main issues in promotion of human milk banks in India? Are there any strict regulations that are needed today to establish and function human milk banks? Like blood banks, do we need to have FDA approvals for human milk bank regulations in the future to maintain the quality? And do you prefer having standalone human milk banks? Like in Pune itself, there are about 6 to 7 milk banks. Is it beneficial that way, or we should form a network here and start it as a first thing in Pune? And the other one is, how do we maintain and sustain the quality of the human milk banks? There is a lot of criticism about the commercialization, and that is why this question was posed. And how do we prevent the commercialization? For Dr. Hima Bindu Singh, who has been running a milk bank for last almost 10 years now, we asked her about the future of human milk banks another 10 years down the line, and how can IYCF chapter of IIP and the IIP itself help in successful and sustainable in these things in India. So what happened is, after all that discussion from various people, this is what I have tried to put together. Of course, it was for almost 30 minutes that panel discussion was there, and 10 minutes were audience questions. So the take-home messages from this panel discussion was not to call any longer human milk banks, but call it as comprehensive lactation management centers as suggested by Government of India, where human milk bank is a part of that center, where you have all mothers coming for various problems of breastfeeding that is solved, as well as lactation support is given. And the bottom line is that when human milk feeding is required and the mother is unable to feed for various reasons, especially in the NICUs, having a human milk bank or a CLMC inside it would always be beneficial. Of course, it comes with a rider that breastfeeding is the best option. And even if your NICU has a milk bank, which is run with the help of milk donated by the mothers, either in the hospital or community, we need to promote exclusive breastfeeding because mother's own milk is the best. What came out from some of the panelists is that community is still not aware of these CLMCs, and they are not aware about the donation practices or the beneficial effects which they can get from having a human milk bank in the hospital or in the community. But all the 5 or 6 panelists said that because of the commercialization aspect which is there, establishment of human milk banks need to be regulated at government levels, because the 122 which I showed you in the map in the beginning, almost 30 to 40 have now stopped functioning, because it is very difficult to sustain, especially they had issues of manpower, funding, and also the sterility of the pasteurized milk, the CMCs of the machines which are there, and the cost of running it. So to establish it, they said there has to be strict regulations. The background of that, when we inquired, is where we came out from the panel discussion, is that human milk is considered as a food, and the FSSAI guidelines are applicable, whereas blood is considered as a body product. And then you are having this thing, what you say, the FDA comes in the picture. So for human milk bank, as of today, we do not have any regulations for establishment. Everybody felt that the CLMCs could be formed as a network rather than standalone, because then there will be a lot of cost benefits, like the cost could be reduced. And of course, the linkages to all NICUs could be done. This is a practice in the Western countries, which is doing very well with the network pattern of human milk banks. The quality assurance guidelines have come from the government, but if you go through it, they are very stringent. And to have those quality assurance guidelines without strict regulations of establishes something which the IYCF chapter today is looking into it, and they are taking it up with the Government of India. We all of us who are in Pune, we could do small quality improvement projects which will help us to identify how we can maintain and sustain human milk banks and be of benefit, as well as it should be cost benefit as well. And IYCF chapter has taken up this particular problem of regulation, as well as the support which is given by the government. Very few places, like in Maharashtra, government of the state government will just help you establish it, but they will not help you maintain and sustain it. But now with the National Health Mission, NHM, I think for all SNCUs, they are coming up with a need for human milk bank. Recently, one was opened up at Jalgaon as well. So every district is likely to have a human milk bank like a CLMC center where it will be. So that is what came out and IYCF has noted down all these points. And the present presidents and these secretaries are looking into it. And we have had a little bit of success after the Kochi conference that the administration now is interested in hearing. And just last week, we had a meeting with the ministry where they will be formulating these guidelines for regulation, as well as they've asked our opinion how we could help them. So that's what the whole thing came out with, some positive results now happening at central government. But the bottom line still remains that mother's own milk is the best. And the second best is the pasteurized donor human milk. So just a request that we have got human milk banks in Pune. I think we need to come together and maybe form a network which will go a long way, rather than we all are independently running them at present. So that is something which IIP Pune also can start looking at. I will request Dr. Keur and Dr. Shirish to look into that part. We have had some success at national level, but maybe we can start from Pune. So I'll stop here, and thank you for giving me this opportunity to present this panel discussion, take-home messages. Thank you.
Thank you, madam. There is one question from Dr. Pramod Jagg, sir. Any discussion about robust Indian evidence for reduction in neonatal mortality related to donor human milk?
Yeah, there are some papers which have been published, which are from centers where the human milk banks have been running. One of them was from our own center. Dr. Khadse madam has published it. And there is another which is from Sion Hospital, where Armida Fernandez madam has published. And there are few articles from KLE Belgaum. So if you could just Google, you can find out. Now, you cannot attribute everything to human milk bank, because the milk is not the only factor. There are other infections, early onset, late onset, antibiotic choice, etc., complications. But what they have given is that if you use human milk, pasteurized also, the reduction in NEC, reduction in sepsis, these two there are already documented evidence, and in Western literature, of course, there are many articles about it. But from India, we have about 10 to 15 such articles, small sample size though.
Thank you, ma'am. Thank you, ma'am, for such a nice, wonderful lecture and giving us overview about the human bank in India situation. And surely we will take your suggestion into consideration about forming a human bank in Pune.
Network can be done, yeah, so there can be sharing, yeah. Okay, yeah, thank you so much.
Thank you, ma'am.
I will just before we go, I will have to leave to attend the Research Society conference. So, Dr. Barnali ma'am, I will be missing your presentation, but I'll definitely take it.
Sure, you know everything, Dr. Rafi.
No, I need to hear from you. Thank you so much. Thank you.
Thank you, ma'am. Thank you. Now I request Dr. Barnali madam to start share screen.
Yeah, share my screen here. Yeah. In the middle, my electricity went, so I hope the screen comes up.
Sure, ma'am. She is a well-known figure in pediatric asthma, practicing since last 30 years in Pune, and she is a master trainer in various IIP modules. It is our privilege to have her with us. She will be talking with us on a topic, asthma phenotypes, endotypes, and its clinical implications. Over to you, ma'am.
Thank you, Keyur. And this is a great initiative. And I casually suggested it to Shirish because in the armed forces, when you come back after a mission, you have a debrief. And so I told Shirish that there were so many of us from Pune and we couldn't even hear each other. And that's a shame. And maybe we should do something. And I didn't truly think that he'll take it up. And I also want to compliment Shirish and his team that I have never felt IIP to be as inclusive as I feel it is now. And Keyur, for the way you've taken this forward. Okay, so going back to Pedicon Kochi, I had the privilege of moderating this session on phenotypes and endotypes of pediatric asthma. And in my panel, I had senior pediatric pulmonologists, 3 general pediatricians. And what I was really missing is pediatric allergists, because asthma belongs to all of us. As much to the general pediatrician as it is to a pulmonologist or an allergist. And there from the audience, we had our very own Deepti and Narmada from Ashok from Vellore, who from the audience participated. And we had a 1-hour, very exciting, illuminating panel discussion. To take it forward for all of you, and also to tell the audience, I saw 100 who are attending, is that it's a futuristic talk. It is to sensitize more than to do tomorrow. So, but how it will be in future is how, we need to be sensitized to. First, an asthma overview. We all know it's now no more a disease, but a syndrome, and it's heterogeneous. No 2 asthmatics are similar. There is variability in onset. One set of parents will say, Kashala sangte dama hai, my child is only 1 year old. And one will say, Kashala sangte 15 varshacha mulala dama hai, for 14 years he had nothing. So there is variability in onset, there is variability in triggers, there is variability in symptomatology, even though there are 4 major symptoms, but in some it may be just cough, which is predominant, in some it could be wheeze. There is variability in response to treatment, and there is variability in prognosis. So you see, it's complicated disease. It's not as simple as the sweet word Dama. Hence, do we need a personalized approach? Probably yes. Now to tell you how we are marching forward, and this all we did in the way of a panel, is that in the past, we only thought of asthma to be a disease of bronchoconstriction. That is why in Marathi, you call it Dama, meaning breathlessness. Or in Bengali, you call it Hapani, which is also breathlessness. And then came a time for many, many years when people said, oh, it all happens because there is hyperresponsiveness of the airways. So I see multiple restrictions coming to me with HRAD and RAD as diagnosis, when you know for sure it is asthma. And we should not deter from calling it asthma, but you still believe that it's hyperresponsive airway disease and it's a reactive airway disease. But why is that happening? It's happening because there is inflammation, and the inflammation is of various cells. And if we don't do that properly, we will cause remodeling. We will cause fixed airway obstruction. Now, the talk globally has shifted from all these things to asthma phenotypes and asthma endotypes. You will keep hearing it. And some of my panelists, very sweetly, when they were in the panel, they said, phenotypes we still know, but what are endotypes? And I sent them a series of 15 excellent articles. If any one of you is interested, just send me a WhatsApp message and I will text you, send you the whole heap if you're more keen to learn about it. Because that's how on the panel, we were all on the same page, because I wanted them all to study and not give them a question that they come pre-prepared. So what is phenotype? Phenotype is an external manifestation, what we observe and the clinical characteristic. And what is endotype? Endotype is the pathophysiology that happens within the airways. It is the various molecules that come into play. It is the internal factors. It's the biologicals. It's the genetic component, which you don't get to see. But it is this that sets one asthmatic apart from the other. Why must I know all this? Am I not doing well? Of course, we are doing brilliantly, but there is scope to do better in future, because if we know the endotypes, then we can have an accuracy in identifying the nature of asthma. Hence, we can give more enhanced effectiveness of our treatment, and we don't do so much of trial and error, and in the bargain cause probably some side effects with drugs. At this juncture, we discussed some Wie's phenotypes of under 5. I'm not talking about it at all today because we have because the transient has become persistent, or it is epidemiological. That is why you say episodic, viral, and multi-trigger. So it all goes in probability. However, Gina also now gives us common phenotypes of asthma. And what are they? Allergic asthma, non-allergic asthma, adult onset asthma, asthma with persistent airflow limitation, and asthma with obesity. As pediatricians, we are lucky. 90% of our asthmatics are allergic asthma. We now see a lot of asthmatics with obesity, so we need to know about asthma with obesity too. That is why we need to know more about the endotypes. Sadly, we do see some asthma with persistent airflow limitations. Those are the ones who have already had remodel because we didn't manage them well. Endotypes of asthma is two types. One is the inflammatory and the other is molecular. The inflammatory, ladies and gentlemen, just remember, is Th2 driven. You remember, Th1 is the infective and Th2 is the allergic pathway. And in the Th2 driven, you have eosinophilic, you have neutrophilic, you have mixed, you have quasi-granular. Molecular endotypes, the world is still waking up to. But that is how is the genetic influence on the disease expression. In the same family or even in twins, you actually don't have the same expression because of the genetic influence. And the omic data. The omic data is also coming up. A quick run through. This went as a panel question as to what are phenotypes and what are types even in Th2 high. So Th2 high, rapidly I'll go through personal history of atopy, dermatitis, food allergy, rhinitis, personal family history of atopy, and pardon me the mistake in the spelling of steroids, a good response to steroids. And the endotypes of these would be eosinophilic airway inflammation, okay? IL-4, IL-5, IL-13, those would be your biomarkers, and eosinophil and mast cell activation leading to IgE synthesis. And in the airway, in the body, what the world is going to move up to. You can, of course, take screen slides, and I can also share you the complete presentation. These are just a few slides of the entire panel. Feel free to ask for it. You can roll it through Keyur or Shirish, or even ask me directly. Th2 low, less common in children, thank God for that, but associated with obesity. And nowadays we're seeing a lot of children with obesity, and they have a variable response to steroids. Again, the spelling is wrong. Here we have neutrophilic and quasi-granular. And again, the molecules are IL-8, 17, 22. In adults, they may be associated with infection. So is there a role of antibiotics and naturalizing them? I love this slide. If you take just a picture of this, you will know Th1, Th high, that's the way it's called, Th2 high, eosinophilic, early onset, atopic. That is why the history of atopy is so important. Or late onset, glucocorticoid sensitive. And TH2 low are non-eosinophilic. They're mainly postgranular or they are neutrophilic. They're late onset non-eosinophilic and they're obesity related. And this lot doesn't really respond so well to ICS. Now you may think that how did this whole gamut of phenotypes and endotypes, who decides? Who decides? Okay, you've told us that this is the phenotype and you've told us this is the endotype. Who finally groups them? So there is method in madness. That is a favorite quote of my dad. For anything he would say, even in madness, there has to be a method. So there is complex statistical analysis, which are either cluster analysis or latent classification. So we identify homogeneous subgroups within a heterogeneous population. My opening sentence is asthma is heterogeneous, but within a heterogeneous population, we find homogeneous subgroups. Now, there was a lot of discussion, which I thought I'll discuss, is that what is problematic? See, the problem only comes when we cannot manage, right? The problematic severe asthma are of two groups, remember. One is difficult to treat, and the second is severe treatment-resistant asthma. Difficult to treat is not responding to the treatment, and they are either a poor technique or it's suboptimal adherence. They're continuing to have allergy exposure. There are psychosocial problems. There is breathing pattern problems in them. So you see, problematic severe asthma is also difficult to treat asthma, and which we can correct. A severe treatment-resistant asthma, which is STRA, is also TH2 high. Don't think it's an exotic group. They're also, they just need to be identified. And probably in them, we need to use biologicals. In a nutshell, I put all this for all of you in this slide so that you know that this is the way we go about. We have a clinical approach and then we have an endotyping approach. In the endotype, we have biomarkers and we have novel biomarkers which are still coming up globally, and there is intense research happening worldwide. I discussed 3 cases. I will discuss only one today because of paucity of time. Maybe when we have the midterm Respicon, we will probably have phenotype and endotype if Shirish and Sanjay Bafna think it deemed right, because the world is moving that way. So I discussed Reshma. Reshma is 15 years old. She has a BMI of 35. She has shortness of breath since last 2 years. And we think, parents think, oh, it's because you're too fat. Khoob jari aahe. Disturbed nights due to cough and tightness in chest since last 1 year. They attribute it to acidity, that she's so fat, she lies down and the reflux probably makes her disturbed through the night. But one fine day, she was breathless at night and they rushed her to the hospital. And it was a month back, and there they did a complete metabolic workup, cardiovascular workup, because she had it all and she was obese. They did a pulmonary function test, and the spirometry showed obstructive airway disease with reversibility, and that's how Reshma landed with me. So now if I ask you phenotype, what is it? You would say that Reshma probably has asthma with obesity. Suppose I give you a rider and I said that Reshma had frequent episodes of shortness of breath and wheeze as an infant, and she was taken to the hospital on and off where she was nebulized. That makes her allergic phenotype, right? What would be the endotype? If you take the second one first, then she becomes endotype of TH2 high because she was allergic right through her childhood. And now she is obese. So you make her TH2 low. I give you another rider that she has snoring. She's obese. She probably has obstructive sleep apnea. So we have another comorbid with her asthma. She's obese. She has obstructive sleep apnea. She also had atopic markers as a child. She was wheezing as an infant. So you see, this is what I want to tell you. The limitations as we stand today is that there is overlapping phenotypes and endotypes. and there is no reliable non-invasive markers. Can you do Bala bronchoscopy and take eosinophils from the airway of all kids who are difficult to treat asthma? Absolutely no. We need to have more reliable non-invasive markers which are still not available. Is FeNO a reliable marker? The answer is no. There could be so many other diseases with raised eosinophil. We still don't have cutoff value, and it probably has some role in adherence in children who are on ICS and not responding suddenly to see are they adherent or not. There is no temporal stability, and most of the data of endotypes and phenotypes comes from USA. There are even very few European studies, and there are only one Taiwan study, and and there is one Turkish study if you can take Turkey in Asia. So there are only 2 Asian studies. There are maybe just a handful of European studies. So can you extrapolate? No, because in asthma, genetics and environment plays such a big role. We have different genetic makeup. Like in vitamin D, we are vitamin D deficient, right? Even sunscreen works differently for an Indian skin. So how can we extrapolate their data to us? And also, our environment is totally different. And there is an emerging entity of small airway disease. That's why FOT is coming up in a big way. In asthma with obesity, small airway diseases are playing a big role. Just a flash slide to tell you all, ladies and gentlemen, there are certain biologicals that are now cleared for children under 6. We don't use it because they are not available. But should you be aware of it? Because you'll be attending talks where that will be mentioned. So again, you can take a screen slide of it. It's like, from one of those science fiction movie. This is how overview of phenotypes and endotypes is going to look at. You see clinical phenotypes, clinical data, inflammatory endotype, molecular endotype, the inflammatory data. One of you has the thing. Jyoti, I request you to please mute yourself because it's coming in the way of people hearing me speaking too. You see the omic data.
Whoever is unmuted.
Sure. Can you please mute them because there's so much background noise.
Madam,
yeah, I can see some of them like Jyoti and all who have it all up there and they're not muted. Okay, so the omics data is going to come up. The molecular endotypes is going to come up, and you will see this is the future of asthma. It is just not your clinical phenotype where I have just said the clinical data. These would be your inflammatory data, and these would be your omic data, which is still unfolding worldwide. But today, what can you and me do? Clinical application of these phenotypes and endotypes still remains under evaluation, but we must know that the world is unfolding. Value of STRA, that's severe treatment-resistant asthma, they need biologics. That's why I showed you the slide how 5 biologics are now cleared for children under 6. But how many need it? Probably 0.1% of the asthmatics that you and me treat. In my asthma practice, in 3 years' time, I might need one who might need biologics. So you see what is available to us. Omalizumab came and then it went. Omalizumab was misused. People use it just for 2 rounds. It doesn't work. And how many, the bottom line is, how many can afford it? The last few lines, asthma still remains a clinical diagnosis for vast majority. So phenotyping, if one message that you can take from today's panel discussion is at least phenotype it, document it, put it in your case sheet. Mild and moderate, most majority, like I said, to the tune of 95% response to inhaled corticosteroids. Intense work is happening globally on endotypes for having precision treatment. Meanwhile, let us focus on delivering best of what is available. We are still not using those resources and that knowledge and not upgrading that knowledge to give optimum treatment. With that, I thank my screen now.
Thank you, ma'am. Thank you for such a futuristic talk. We really need to study and learn more about endotypes and phenotypes. There is lots going on in this. So we will hear it from you more and more. Sir, yes, sir. So you have a question.
Yeah. So Barnali, just now when you are in the process of identifying these little difficult to treat varieties, what would be your optimum time to understand whether the child is responding well or otherwise?
3 to 6 months.
3 to 6 months.
Yeah, ensuring that
the compliance is correct.
Adherence, technique, avoidance of allergies, any psychosocial factors, and have you actually done a spirometry right at the beginning, and have you documented it? And if you've done a spirometry and it was ambiguous, then probably you need to do a FOT, because you might have small airway disease in which you need to use different molecules, which will probably go into the smaller airways better. So, before giving up on kids, 3 to 6 months, but you need to talk to the parents, tell them that, look, I know what I'm doing, just trust me.
Going to the ICU for an acute flare-up and then has lot of other comorbidities like obesity and all that, would you be thinking
FOT, and which showed small airway disease? So I've actually put her on the molecule, which is, a small size beclomethasone along with formoterol, and she's actually doing very, very well on it. So if we do biomarkers, that is the future. But yes, biomarkers and omics first have to be available, they have to be reliable, and they have to be affordable. So once I have overcome all those hurdles, yes. But I would like to know about it. I'd like to know that available, affordable, and and I should be able to use it for that small variety of patients whom I can also give back a new normal life. But till then, I will use whatever science skills I have to use it optimally.
Perfect. Thank you. Thank you so much.
There was one question, ma'am. Any role of prebiotic in asthma? Can you answer it just short? In short.
So again, the gut-lung, thing is pathways coming up in a big way, and lots of pharmaceuticals are giving us a lot of prebiotics. When it was a launch, I used, to keeping my mind open. And I'll confess, I didn't have any good results. And I thought I'm just adding on to the cost. However, a very dear friend of mine who's a pulmonologist has actually now invested in a company in which they are making probiotics. And he's saying it's good results. So I told him, tell me after 6 months, when your cost of investing has gone. So I don't know whether to trust. But it's a very good question. And I'll keep it in mind, and I'll come back to it on IIP Pune in future. Sure.
Thank you.
As of now, don't keep writing all those and increasing the cost.
Sure, ma'am. Thank you. Thank you.
Can I just make a comment?
Go ahead.
Yes, Keyur, sometimes these newer devices which are so-called have postulated role in treatment of asthma can become a deterrent.
You muted, Shayan. You muted. We can't hear you.
Your voice is muted, sir.
Yeah.
Is it audible now?
Yeah, now you are.
Yeah. So I think one more aspect of these emerging therapies is that, with the advent of these therapies and we implementing it in our practice, it can sometimes give a wrong signal to the parents. And the focus on giving the correct initial therapy can get diverted. So diluted. So that is one risk of that.
Thank you, sir. Thank you, sir. So we are a bit slow in our overrate, sorry. So Thank you, ma'am, for such a nice overview for her topic. Now, I request Dr. Dipti Pujari, ma'am. She is an allergy specialist certified by European Academy of Allergy and Immunology, currently working as an allergy specialist in the Nanath Mangeshkar Hospital. She will be talking about allergic rhinitis, a marker of asthma. So please start, share screen, ma'am, and go ahead with your lecture. Thank you.
Thank you for giving me this opportunity. Please excuse my sore throat. I'm having bad cough, cold, and fever, but I'll just somehow manage. Thank you, Kankaria, sir, and Dr. Keyur for managing this so well. Okay, so why? Yes, I have started my stopwatch, so I'll be finishing in 10 minutes. So the question is, allergic rhinitis, a marker for asthma. Why this topic was given to me in the first place? What is the need for this topic? As we see, there are a lot of epidemiological links between rhinitis and asthma. The vast majority of asthmatics have rhinitis. Many patients with rhinitis have asthma. Allergy and occupational agents are the causative factors for both rhinitis and asthma. Non-allergic rhinitis also associated with asthma. The coexistence of rhinitis with asthma appears to impair asthma control, a very important point. Most asthmatics exacerbations are associated with nasal viral infections. So with these epidemiological links, I was given this topic to prove it or otherwise. So some observations by IRIA 2023 guidelines, according to it, the management of allergic rhinitis and asthma comorbidities, the presence of asthma should always be excluded in patients with allergic rhinitis, especially in those with moderate to severe persistent rhinitis. Severity of rhinitis was positively correlated with a score of asthma severity. And so it was seen that approximately 30% of the patients with rhinitis, they develop asthma at some point of time. It was a very important paper published in 2020. Also, it was seen that majority, almost 100% patients with allergic asthma experience rhinitis symptoms sometimes. So yes, there is a strong correlation. So I thought I'll quickly put this study, a 23-year-old follow-up of college students. It showed significantly more, 10.5% of the students originally diagnosed with allergic rhinitis went on to develop asthma, compared with only 3.6% of those who did not have rhinitis. And this 10.5 was statistically very significant. Another longitudinal study, which went on from 1968 to 2004, it showed childhood allergic rhinitis increased the likelihood of new onset asthma after childhood and the likelihood of having persisting asthma from childhood into the middle age. So what were the clinical implications? Asthma burden in later life might be reduced by more aggressive treatment of allergic rhinitis in early life. I have excluded some other very important studies for want of time. So with some studies we have proven, but is it really so? What is this one airway, one disease, united airway disease? We keep talking, but does it really exist? So when I was going through the literature, we found out there were some similarities between upper airways and lower airways. So there are anatomical similarities, physiological similarities, pathological and immunological similarities. Let's quickly see. So anatomical and histological similarities between upper and lower airways, they both have pseudostratified epithelium with columnar cells, a basement membrane, lamina propria, submucosal layers, seromucinous glands, fibroblasts, inflammatory cells, goblet cells, nerves, and muscles. So this is our nasal mucosa with all these cells, and this is our bronchus, again with exactly the similar cells. Even in abnormal airway remodeling, in allergic rhinitis, there is epithelial shedding, goblet cell hyperplasia, excessive mucus production, basal cell hyperplasia, basement membrane thickening, subepithelial fibrosis. This is our nasal mucosa, and everything same is in the bronchus. The only anatomical and histological difference between the upper and the lower airway is this smooth muscle, which is present only in the bronchial mucosa. Here we can see this smooth muscle hypertrophy, which is not present in nasal mucosa. Rest everything, shredding, collagen hypertrophy, eosinophils that are present, the T cell hypertrophy, the collagen deposition, fiber, almost everything is similar in nasal and bronchial mucosa. So definitely a lot of anatomical and histological similarities between upper and lower airways. What about the pathophysiological mechanisms linking the upper and lower airways? 4 ways the link has been shown. Aspiration of nasal inflammatory cells and mediators into the tracheobronchial tree, hematogenous propagation of inflammatory mediators from one part of airways to another, stimulation of bone marrow progenitor cells, and the nasobronchial reflex. So as we see rhinitis and non-specific bronchial hypertrophy, whenever there are pollutants, allergens, infections, irritants, they cause nasal inflammation, leading to nasal congestion, mouth breathing, breathing of cold air, and bronchial hyperactivity. Not only this, through the bone marrow progenitor cells via leukocytes, there is again a bronchial hyperreactivity. So hematogenous spread is also there from upper to the lower airways. A very important nasobronchial reflex. Trigeminal nerve, it acts as an afferent sensory innervation to the nose. So these receptors are localized in all the upper airways and lower airways. Any mechanical and chemical factor like cold, dry air, pollutants, or any irritants or allergens, the signal via trigeminal nerve goes all the way to the medulla and comes down via the vagal efferent to the lower airways. So there is immediate bronchoconstriction in asthmatic patients with signs of severe allergic rhinitis. A strong correlation was shown. So what are the triggers of this reflex? Infection, smoking, pollutants, cold air, physical exercise, they all trigger allergic rhinitis and asthma, both. Again, showing that yes, allergic rhinitis could be a marker for asthma. And then there are some common risk factors like aeroallergens and occupational agents. I'm not at all going into the details of this. What about the immunological similarities? Banali ma'am had already shown the slide. Allergic rhinitis and asthma both have Th2 mediated response, IgE mediated hypersensitivity, increased eosinophilic counts, and cysteine leukotriene inflammatory lipid mediators like LTC4, D4, and E4. So strong immunological similarities. So we have seen anatomical, histological, pathological, neuroreflex, and now immunological similarities are also there. So this is what I meant with all the immunological similarities. They both have interleukin-4, 13 mediators in their bronchial and upper airway inflammation. With these similarities, is there a treatment link? Because ultimately, the patient needs to benefit. Why are we discussing this? Because the end result, what we want is the patient should be better. So allergic rhinitis management is associated with better asthma control, and likewise, the improvement of asthma was associated with the resolution of allergic rhinitis, a very important paper published in Allergy in 2007. And it also showed that intranasal corticosteroids used for treatment of rhinitis are associated with better control of asthma symptoms and vice versa. And immunotherapy was found to prevent the development of asthma. So again, a big treatment link was seen between the allergic rhinitis asthma. Immunotherapy, strong evidence is now present that you treat allergic rhinitis, you can prevent the progression of asthma. The 2023 guidelines have clearly mentioned that. So why is it important? The golden question. Failure to recognize this complexity or to treat both upper and lower compartments of the airways inevitably leads to suboptimal outcomes for the patients. So allergic rhinitis and impact of asthma, ARIA 2023 recommends patients with persistent allergic rhinitis should be evaluated for asthma by histories, chest examination if possible when necessary, assessment of airflow obstruction, before and after bronchodilator. History and examination of upper respiratory tract for allergic rhinitis should also be performed in patients with asthma. And then to propose a strategy combining the treatment of both upper and lower airway disease in terms of efficacy and safety. So my final slide, take-home messages: United Airway Disease is characterized by inflammation of the respiratory tract, in which rhinitis and asthma are upper and lower respiratory tract manifestations respectively of the same disease process. There is a systemic inflammatory response. Patients with rhinitis or asthma should always be assessed for coexistent disease in the reciprocal area. Treatment of the upper airway disease can modify the severity of lower airway disease and vice versa. The potential for early treatment of allergic rhinitis to prevent the progression to asthma is well known, but merits further studies. Thank you. So my alarm goes off.
Thank you, ma'am. There is one question from Dr. Pramod Zak sir regarding concomitant use of inhaled steroid and intranasal steroid. So can you please comment on that?
So both being local, they're extremely safe if safety is the concern. So that's why the ARIA recommends first examine, prove if there is allergic rhinitis, concomitant use of intranasal steroids, and if there is asthma, concomitant use of inhaled corticosteroids, they should go hand in hand. That's exactly what the ARIA 2023 guidelines recommendation is there, if we have proven that both coexist, not otherwise.
Thank you, ma'am. There is one more question.
There is one more question.
Yeah. Just
again,
right.
Montelukast is a very controversial molecule at the moment, but if at all there is any role of Montelukast, then it is when asthma and allergic rhinitis coexist. So very little role of Montelukast in pure allergic rhinitis, very little role in pure asthma, but when they both coexist, that is when Montelukast has a good response as an add-on therapy, not a primary therapy, not at all a primary. Primary still has to be intranasal and inhaled corticosteroids.
If they coexist and we cannot manage with ICS-NI, even if they coexist and we can still manage with ICS-NINS, it is only if you still can't manage.
Yes. Yeah.
Thank you, ma'am. Thank you for enlightening us about at SK Medical College and Hospital. He has a keen interest in pediatric respiratory diseases. He has a various publication under his name, and now we are privileged to have him with us. I request him to start his presentation. He will be talking on inhaler or beware. It is the debate on inhalation therapy. Over to you, sir.
So at the outset, I'd like to thank Shirish, Lalit, Amol and his team, and of course, KU, who have given me this opportunity to present this discussion in the IIP Pune group. Excellent initiative, Shirish, and मला असं वाटतं अरे आपण कसं नाही याचा विचार केला. So very nice initiative. Thank you, Shirish, for that. Just as a initial slide, these are the panelists which were there with me at Pedicon. Our own Dr. Sharad Agarkar sir was one of the panelists for us. As a generality, panel discussions are more about discussions, and the idea would be to get across the take-home messages. And that is what I'm going to try to do in the next 10 minutes. Some of these will be repetitions of which you already know. Some may be a little bit of new things which you can learn about. So beginning my first slide with take-home messages itself. So I think one important thing is there is no debate. Inhalation therapy is here to stay, and there is no debate there. Barnali Madam has already alluded to probability-based diagnosis of asthma in children in less than 5 years. Pressurized meter dose inhaler with spacer plus or minus mask is the best option for most of the patients with children with asthma. Nebulizers have a very narrow role in specific situations and are not an answer for all problems with the respiratory system. AIR and MART are part of recent guidelines, and one needs to be aware of why, and we'll see briefly what these two are. And of course, inhalation therapy has a role in several conditions other than asthma, which also have their own importance. So first important thing which we need to highlight on is the use of spacers. So one has to remember that spacers are recommended. It is recommended that metered dose inhalers are used together with spacers, even for older children and adults ideally. We all know spacers overcome the challenges of actuation in and inhalation coordination, reduce the oropharyngeal deposition, and they're more effective than nebulizers even in acute asthma exacerbations. So the idea is spacers are the way to go. To mask or not to mask, so very clear guidelines, less than or equal to 4 years, masks are to be used. More than 4 years, we would try to avoid use of mask because there is increased dead space and leaks are likely to be there. But you have to take it case by case because some 5-year-old children may also not be able to handle the spacer without the mask. So you have to take it case by case, but in general, less than 5 years, less than 4 years, you would definitely use a mask. Above 4 years, you'd like to avoid using the mask. Of course, when you use the mask, proper size and fit, good material, and it should be covering both mouth and nose. These things are to be remembered. One recent interesting development is, of course, the breath-actuated pressurized metered dose inhaler. It is available nowadays in most of the combinations and standalone inhalers as well. It overcomes the coordination problems. Here, the drug is actuated automatically based on the flow generated by the patient, and a very low flows are required to actuate the drug. Drug deposition in the lungs is almost equal to PMDI with spacer. So breath-actuated metered dose inhalers are, of course, going to be the future, and they can be used even by small young children as well. So just a small case snippet to highlight certain points. A 2-year-old child was brought with cold, cough, and fever since 2 days, past history of previous 3 episodes in the last year, where cough lasted for about 2 to 3 weeks. The child also has a history of intermittent cough in between. Clinically, he has mild tachypnea and bilateral bronchi on auscultation. He has been advised oral salbutamol with antipyretics and decongestant, same as in the previous 3 episodes. So now, is this child having asthma? And as Barnali Madam was talking about, we have to look at the probability-based diagnosis of asthma, which has been now highlighted by the GINA. Here we look at 3 or 4 things. One is the symptoms, whether they are lasting for less than 2 days or 10 days or more than 10 days after an upper respiratory infection, the number of episodes per year, and the child has been symptom-free or having some symptoms even in between the episodes. Along with that, we also look for the allergic sensitization, atopic dermatitis, food allergy, and so on. And depending upon that, we classify the children as based on probability, whether they're under 5 users with low probability, those with moderate probability, and those with high probability. And depending upon that, we decide the management. So this child, which I discussed, was under 5 user with moderate probability of asthma according to this probability-based diagnosis. Now, let us just consider that this was only the first or second episode. Now, the treatment, would it be justified? Oral salbutamol with antipyretic and decongestant? So no, actually, because what happened in this case demonstrates why. The patient came back next day with no improvement, irritability, and parental complaint of tremors in the patient. So he was now advised nebulization. So the idea is, if you give oral salbutamol, there are likely to be hardly anything reaching the lungs, and it is likely to give rise to unwanted side effects as well. So oral salbutamol, hardly any role in management of such patients. Now, this child was advised nebulization which is often done by many of our colleagues with a combination of salbutamol and ipratropium. We know the popular brand. Now, what is the opinion? Is this prescription justified? So we come to 2 important parts here. What is the role of nebulizers in asthma? And this is a very important thing which we should remember, that the nebulizers have a role only in severe acute exacerbation of asthma with hypoxia. And here too, it has to be an oxygen-driven nebulization. It also may have some role in physically challenged patients which are not able to manage a pressurized metered dose inhaler and spacer, or bedridden and unconscious patients. So this is all where the nebulizers are to be used in asthma. What is the role of ipratropium, so commonly prescribed in our practice? So it is only as an add-on drug to the short-acting beta agonist in acute severe asthma in a child who has not responded to only SABA. Usually it is prescribed for a short time, not more than 48 hours for sure. Now, this child, you are convinced that the patient deserves a trial of inhaled corticosteroids, but the patient say that they have now purchased a nebulizer at home during the previous episode and want to use the same for nebulization for this child, even for the trial of inhaled corticosteroids. So what is the logic behind it, or is there any logic? So there are several problems with the use of nebulizers, which we all know, but just to highlight, the drug delivery is not reliable. There is a lot of wastage of drug. Nebulizer maintenance is an issue which is often overlooked. Home nebulization often leads to unwarranted excessive use. There is very high dose sometimes given. More time is spent, high oral deposition, and so on. So hardly any role of nebulizers, especially hardly any role when you are giving inhaled corticosteroids. Coming to the next point, why are GINA and all the other guidelines hyping on MDI versus nebulizers? So here's a very interesting slide which I have borrowed from the Casper. We can all have a look at this slide, which shows that the MDI with spacers has the maximum deposition in the lungs. There is some comparison with the dry powder inhaler, but if you look at this part, in the oropharyngeal, so the DPI has a lot of deposition in oropharyngeal area. The MDI with spacer has maximum deposition in lungs, hardly any deposition in the oropharyngeal area. That is why MDI plus spacer, with or without mask, is the way to go. Now, the next point is a 13-year-old child diagnosed as asthma, and he started on SOS SABA by someone. So what are your comments? So now GINA has been very unequivocal in this. GINA says that it is not acceptable to manage a child, especially an older child with asthma, with SABA and oral corticosteroids instead of preventive ICS containing treatments. What is the risk of SABA only treatment? So several problems. It can give rise to decreased bronchodilatory response, rebound hyperresponsiveness, worse long-term outcomes with monotherapy, higher risk of severe exacerbations, even higher risk of death if there is overuse of only SABA. And inhaled corticosteroids reduce the risk of asthma deaths, hospitalization, and exacerbations requiring oral corticosteroids. So only SABA treatment, especially in older children, is not to be prescribed at all. Coming to this important point, AIR. So what is anti-inflammatory reliever? So the conventional pharmacological approach has been in mild asthma is to give relievers in the form of SABAs. However, anti-inflammatory maintenance with inhaled corticosteroids is used only for more persistent asthma. But what happens is over-reliance on SABA and poor adherence to maintenance therapy may give rise to an increased risk of morbidity and mortality. On top of that, there may be poor long-term lung function. So combined anti-inflammatory and reliever medicines in a single inhaler have the potential to overcome these limitations. And this is achieved with the help of ICS, that is inhaled corticosteroids with formoterol, or ICS with SABA. This provides rapid relief along with a small dose of ICS, reduces the risks of future exacerbation compared to SABA monotherapy. One of the last points is what is MART? So MART, if many of you may be knowing, it is maintenance and reliever therapy with ICS and formoterol. A low-dose ICS formoterol combination is used as patient's maintenance treatment plus when you're needed for symptom relief. And the logic for that is that formoterol, though it's a LABA, that is LABA, it also has a rapid onset of action. Remember, salmeterol does not have that. Only formoterol has a rapid onset of action, thus providing immediate relief and a more sustained bronchodilatory effect compared to salbutamol. So the additional ICS, which is available with formoterol, it also helps in better control of the airway inflammation and decrease in the future episodes of severe exacerbations. Of course, there are several other indications for inhalation therapy which we have discussed, that is bronchiolitis, croup, cystic fibrosis, where you use nebulized antibiotics and so on. So again, to sum it up, inhalation therapy is here to say probability-based diagnosis of asthma. It is very useful for us in practice to explain to the patients about this probability-based diagnosis. PMDI with spacer plus or minus mask is the best option. Nebulizers have a very narrow role in specific situations and are not an answer for all problems with the respiratory system. AIR and MART, that is anti-inflammatory reliever and maintenance and reliever therapy, are a part of recent guidelines, and one needs to be aware why. Inhalation therapy also has a role in significant and several other conditions other than asthma. Thank you.
Thank you, sir. Thank you for such a nice presentation regarding inhalers. But the major hurdle which we face in as a pediatrician in
I cannot hear you.
Can you hear me, sir?
Yeah.
So thank you for such a nice presentation. The major hurdle what common practicing pediatrician faces is when we counsels at the first time to start inhalers. So do you have some tips for that?
So as is commonly done, we have to explain them why inhalers are the right way to go, because if you're going to give oral therapy, the hardly any drug is going to reach where it's supposed to act. And there are a lot of side effects associated with oral medicines, which can be overcome by giving inhaled medicines. So yes, actually, we need to spend time with the parents and convince them. It is the most important thing, spending time with the parents, giving them more of our time and explaining how it is going to be beneficial for using inhalers rather than oral therapy.
Sure, sir. And there is one question from Dr. Pramod Jog, sir. Any word about serum potassium with salbutamol inhalation?
So yes, excessive salbutamol nebulization is also going to cause, is going to affect the serum potassium levels, is likely to decrease the serum potassium levels, as we all know. Yes, that is one of the problems with excessive use of oral, with repeated salbutamol only nebulizations. Yeah. Barnali madam wants to add something.
No, it's just that we don't say anywhere to give potassium even when they are nebulized with SABA, because it's for a short time. And we have to remember that it is the hypoxia that you are treating more than the bronchoconstriction. So it is at that point of time in an acute flare-up, it's oxygenation. So this hypokalemia is much hyped. At least if it's hyped, we should at least move away from nebulization and not. But I think Sanjay, excellent presentation.
Thank you.
Thank you, ma'am.
There's one more question about Montelukast duration and indication. So I think indication has already been discussed. Remember, it is an add-on drug, not to be used as a first line. And in general, long-term Montelukast use has been documented to have several side effects. So it is better to avoid using Montelukast in general.
So there is much apprehension about use of Montelukast. There is lots of discussion.
See, what happens is nowadays, sorry Keyur, to interrupt, but even for a short viral cough also Montelukast is being given left and right. So that needs to be avoided. I think there is hardly any role of Montelukast there.
And the second thing is, may I just give a comment?
Viral cough.
Second thing is, it comes in a combination. The levocetirizine Montelukast combination is the most unethical combination. So that you must keep in mind.
Even if we prescribe
or fexofenadine,
we can discuss at this stage.
Sorry, Keyur.
So the question is about duration. So for what duration we can prescribe?
Or so ideally, I will not be prescribing Montelukast at all.
No. If it is needed in asthma, if it is needed in asthma.
If it is needed, then it is given for a period of 3 months before writing it off. But in the past, all of us would write, right? And now we are aware of what is not right, because it comes with a black box warning. And that time we used to say, if you do use it for a period of 3 months. And what Sanjay and Jayant was saying is that people now use Montelukast with any antihistaminic for any viral cold cough. Do not do that. Like, it's a drug which is also idiosyncratic. You never know which kid you're pushing towards night terrors, you know. Retrospectively thinking, some of my parents, I remember a dentist who had told me that his child is getting nightmares. This is good 15 years back. And I actually brushed it under the carpet because I was ignorant. And now I realize that it was happening, right? So we have to evolve and grow. I mean, there's no point can you say, I know enough. Yeah. We never know enough in medical science.
The message is crisp and clear that do use Montelukast very cautiously.
Last word, I would like to just acknowledge Barnali ma'am's contribution and Dr. Pramod Kulkarni's contribution in preparing this panel discussion. Thank you, ma'am.
No, you did very well.
Thank you, sir. Now, I request Dr. Rajesh Kulkarni, sir. He's a well-known pediatric pulmonologist from Pune, the associate professor at KG Institute of ICM. He has various research articles published nationally and internationally. And he will be talking on chronic cough in children.
Okay, am I audible and visible?
Yes, sir, you are audible. So you can start, sir.
So, disclaimer, I am not a pediatric pulmonologist. I am a general pediatrician.
Yes.
Yeah, so thank you IIP Pune for giving me this opportunity, Dr. Shirish, Dr. Keyur. And this is the presentation from Kochi, obviously. So chronic cough, the definition that is most accepted is a persistent cough, which means it has to be daily and it has to be for longer than 4 weeks. And why this 4 weeks was kept? Because 90% of acute cough would resolve in 3 weeks. So what remains is likely to have a underlying etiology. And studies have shown that 18 to 30% of children with chronic cough will have a serious underlying condition. So whenever you have a child with a chronic cough, bear in mind that this could be a significant disease that you are diagnosing and a symptom of that disease. So we all know that the chronic cough could be pulmonary or extrapulmonary. And the pulmonary causes are aspiration, asthma, endobronchial suppurative disease, pneumonia, foreign body, and so on. Whereas the extrapulmonary causes are cardiac and habit cough or psychogenic cough, sometimes even medication. Now let us look at when we get a child with chronic cough, what history we like to take. So the first thing is the age of onset of the cough.
Sorry to interrupt. Someone is unmute. Please mute themselves.
So is it neonatal onset, infant onset, young child, or an adolescent? Is it a sudden onset cough, a gradual onset cough? Is it a wet cough or a dry cough? What is the timing of the cough? What is the event that has happened before the cough has started? Is it immediately or sometime after lying down, nocturnal, waking up in the morning? Are there any aggravating or relieving factors, and are there any accompanying features like fever and breathlessness and weight loss? So that is the cough history we take. So if we see why age is important here, in infants, you're likely to more deal with airway malformations, tracheoesophageal fistula, and incoordination. Some infections like pertussis and chlamydia and RSV, which are more in infancy, and rare diseases, sometimes a cystic fibrosis. In a preschooler, you probably would be worried about foreign body, a prolonged viral infection, and asthma, and passive smoking, again, very important. In a school-age child, you think of asthma more, upper airway cough syndromes, irritants, and habits. Now, these are some of the cough characteristics. I have tried to capture these coughs. I don't know if the audio will play properly, but let us try it. So we have the dry cough, then the staccato cough, and then the wet cough, which will play out. So first the dry cough. Now the staccato cough in each child will cough, and this will characteristically see in chlamydo. Wet cough that we classically see in protracted bacterial bronchitis. I think in IIT Pune group we had a lot of discussion about this PBB, and this is the cough they will come with. Now let us enter this to barking cough or honking cough. That would be indicating a somatic cough, although it is not diagnostic, but it is common. That was associated with this honking cough. Now let us listen to this brassy cough that I think all of us must have heard. Group. And finally, pertussis causing a paroxysmal whooping cough. I think not uncommon. We have diagnosed nearly 50 cases in the last 1 year. So it is a very common thing. Unfortunately, we don't investigate, so we don't know it is pertussis. Very common in our community. Okay, so now cough pointers. So I think this is the most important part of today's talk. And this has come from 2020 chronic cough guidelines. So what are cough pointers? So basically these are diagnostic clues that identify an underlying etiology for chronic cough. And based on these cough pointers, we classify cough as either a specific cough or a non-specific cough. So what are the cough pointers that you would elicit on a history? So if you have a child with a chronic cough, what history will you ask? So obviously you'll ask if there was a choking in the past. Is the child having any exertional dyspnea, feeding difficulties, hoarse voice, or a stridor that indicates an airway abnormality? A hemoptysis will tell you a suppurative lung disease or a vascular abnormality. A daily wet purulent cough will tell you this is a PBB or maybe a bronchiectasis. The child is neurodevelopmentally abnormal. It will tell you it is an aspiration, maybe an aspiration. A recurrent LRTI. So is this a systemic immunodeficiency type you're looking at? Or a recurrent lung infection? That is what you need to look at. In addition, if somebody has a purulent nasal discharge, this could be just a chronic sinusitis, which is again common with the PBB. If there is a history of chronic lung disease, for example, in the neonatal period, then you could link the chronic cough to that, or a H-type fistula. Many a times, GER is blamed for chronic cough, and it is important to note that blindly prescribing anti-GER measures to a child with chronic cough will not work. So unless there is a very strong history and symptoms that suggest that there is GER, and you've proven that there is a GER, there is no point just giving therapy for GER to a child with chronic cough. So what history will you ask? History of recurrent regurgitation, dystonic neck posturing, heartburn or epigastric pain in an older child. Drugs, very important, that if you get a referral maybe from a, you are dealing with a cardiac patient, for example, and that patient is on captopril or propranolol, that could also cause chronic cough. If the child is unimmunized, beware of pertussis. If the child has atopy, I think we have discussed this in detail, and asthma. What are the examination pointers? So growth failure will tell you this is a serious systemic illness. Again, the importance of growth charts. The clubbing will tell you suppurative lung disease. A chest wall deformity, a tachypnea will tell you this is a pulmonary or parenchymal disease, or an hypoxia and cyanosis will tell you the same. Now again, wheeze. Is this a monophonic wheeze or a polyphonic wheeze? A polyphonic wheeze you commonly see in asthma. A monophonic wheeze is characteristic of an airway obstruction. So this could be a foreign body, it could be a lymph node which is pressing on the airway, or a mediastinal tumor even. Crepitations. So if you have an airway disease or a parenchymal disease, you might get crepitations, and even an interstitial lung disease will have some crepitations. So these are the pointers I have just mentioned them again. So the approach we said is either this is a expected chronic cough, which has lasted post-virally for a little longer than maybe 4 weeks, or this is a non-specific cough where there are no cough pointers. So on history and examination, what cough pointers we discussed, they are not present in this child. This is a dry cough. So dry cough is little reassuring, and the child has a normal X-ray and spirometry, whereas a specific cough will have cough pointers and they will have a etiology, specific etiology. So let us little bit discuss about this very common entity called PBB. So essentially it is a wet cough. Very important to remember that it's an isolated wet cough that's going on for more than 4 weeks. And other cough pointers will not be there. So there will be no symptoms or signs of another cause. It may respond to 2 weeks course of amoxiclav. Now, normally we give amoxiclav for 5 days or 7 days, but here you will need a longer duration and sometimes the extension of the duration also to further 2 weeks. If this is a recurrent problem, if you're diagnosing second time of PBB, I think you should send the child to a pediatric pulmonologist. Now, a word about this psychogenic cough, what we used to call somatic cough. So somatization basically is conversion of psychological symptom into a physical symptom. This is a diagnosis of exclusion, but usually will occur after an URTI. And then the child, it becomes a habit for the child to continue coughing, even when there is no need to cough. And the characteristic features are dry, honking type of cough. And very importantly, the cough will be absent during sleep. I think all of us must have seen this type of coughs where the child will not cough in the night, but throughout the day, the child is coughing. So this is an important entity. A habit cough, on the other hand, has features of variability, suppressibility, and distractibility. There might be associated tics. So motor tics, phonic tics may be there, throat clearing may be there. And these children do well with behavioral therapy. We'll just quickly go through some clinical cases. So we have an 8-year-old child who is very malnourished, pale, and there is a history of Cox contact, GeneXpert positive, and this is the CT. This is a 4-month-old who is born of a consanguineous marriage, has low-grade fever and cough for 1 month, has a weight loss of 700 grams. There is no Cox contact. There is a strong history that the elder sibling had died of similar illness at around 6 months. And the chest X-ray showing you haziness in the left lower zone. And this is the ABG that is showing you problem which is there. And you got a metabolic alkalosis and a hyponatremia, hypokalemia, hypochloremia. So we did a sweat chloride stat and it is positive. Now in this child, actually, this is a small baby, so probably testing for gene would be better. Again, this is a 6-year-old child, chronic wet cough, 6 weeks, purulent cough, worse, early morning, child has clubbing. The HRCT tells you what the diagnosis is, bronchiectasis. So I think the take-home messages from my side is that the chronic cough is a cough which is daily, persistent, and which is longer than 4 weeks duration. Most of the chronic coughs that you see will be non-specific coughs, which would probably resolve. These are mostly post-viral, but beware of cough pointers. So if you have specific cough pointers, these indicate specific etiologies. And not only the first visit, but these cough pointers have to be reviewed at each visit. So every time the child comes, you need to ask about these cough pointers and you need to examine the child again carefully. In our country, we should not miss 3 diseases: asthma, foreign body, and tuberculosis. And all 3 can come with a chronic cough. Psychogenic cough, tick cough are not uncommon entities. I think increasingly we are seeing these entities. Any child who has a chronic wet cough, think of a suppurative lung disease, and these need appropriate reference. Thank you.
Thank you, sir. Thank you for such a nice presentation. Just a small word on protracted bacterial bronchitis. If at all we want to treat it, how and for what duration we should treat?
So minimum of 2 weeks of amoxiclav. Has not responded, then you warrant a pediatric pulmonology reference, 30 to 50 mg per kg.
Thank you. Thank you, sir.
Use plain amoxicillin also, but there is a concern that there might be a resistance. So we are going to use amoxiclav.
Okay. And is there any lab diagnosis to confirm PBB?
No, there is no, per se, there is no diagnostic test. So if you have a persistent wet cough and the child doesn't have any abnormal examination, the child is otherwise going well and everything else is okay, then you think of a PBB. You could do an fiber optic bronchoscopy, you could do a bronchoscopy and send for culture, but I think in routine practice is not done.
Okay. Thank you, sir. Thank you very much. Now I request Dr. Jayant Joshi, sir. He is a well-known figure in pediatric respiratory medicine, has many publications under his name. He's a trainer and faculty for various IIP respiratory modules. And he will be speaking about chronic cough approach to investigations. Sir, I request you to start share screen and start your lecture. Jayant Joshi, sir?
Yeah.
Yeah, sir.
Is my screen visible?
Yes, sir. Yes. There's a full screen, kara, sir.
Yes, yes. Am I audible?
Yes, sir. You are audible, sir.
Okay. So thank you very much. I think I'm the last batsman in this league and probably has a little advantage of exceeding the timeline because the thing is, in this particular presentation, I was privileged to have Dr. Rajesh as a part of our panel. It was a 1-hour panel discussion on chronic cough and we were assigned different roles. So as Dr. Rajesh has elaborated on so many things, I will briefly go through some things which are already covered by him. And then I'll just make more emphasis on the investigation. This has been mentioned to you already. Chronic cough broadly accepted more than 4 weeks. Decision to investigate will depend upon the history and physical findings. A chronic cough in a very young infant will point towards the possibility of congenital anomaly. History of atopy and chronic cough suggests a possibility of asthma. Red flag signs, as mentioned by Dr. Rajesh, very important clues. And the character of the cough, either specific or non-specific, is an important factor. History findings, I think I'll not go through this. They've already been elaborated. These are the red flag signs, auscultatory observations, the clues possibly like clubbing and other growth failure, etc., which are pointing towards various chronic respiratory problems. Now, categories, there are generally 3 categories which are overlapping when you tackle a problem of chronic cough. A child with a chronic dry cough with no specific abnormal findings in history of physical examination. Then a relatively normal child with a recurrent episodes of acute cough from an upper respiratory tract infection with or without asthma variants or comorbidities like allergic rhinitis. And the last category, child with a specific type of cough with key red flag signs and unremitting or worsening nature of cough. So the chronology of events in evolution of these symptoms is to be always considered before investigating further. As we all know, chest X-ray is the basic investigation which you would be ordering for any chronic cough. In fact, it is said that it is an extension to the physical examination. But remember, while you technically assess the X-ray, always keep in mind various technical aspects of it also, like the projection, orientation, rotation, and penetration. Because if they are not properly maintained, then you can sometimes make an error in interpretation. Now, an abnormal chest X-ray is a reliable indicator with a high specificity, but carries a poor sensitivity. So the utility of X-ray we know in various chronic conditions. I'll just briefly run through it. Like for example, in this you see an hyperinflation. This is related to a foreign body aspiration. You can have a bilateral, I'll just read the cursor here so you can see a foreign body here, and you have a hyperinflation on the side. This is a typical right middle lobe syndrome frequently seen with obstructive airway disease like an asthma. As you can see a consolidation pattern here. It may also be caused by other causes like immunodeficiency. So we have to keep that in mind. Mediastinal widening as seen in this X-ray is often seen with marked lymphadenopathy or neoplasm. Sometimes thymic enlargement is also a very important reason. You have to identify that. In TB diagnosis, chest X-ray has a significant role. As we know, there are certain patterns of tuberculosis which are considered relevant from their X-ray observations, like the consolidation with a cavity inside or a primary complex with a hilar lymphadenopathy like this, or you can have a biliary tuberculosis. So these are classic presentations. And sometimes you can even have a good quality chest X-ray which can give you a diagnosis. As you can see in this is a foreign body here. So X-ray is invaluable provided the quality is maintained. The other diagnostic modalities available at our resources are ultrasonography. It is very safe, non-invasive, easy to perform. It is more useful in acute scenarios, even bedside, when quick decision making is required. Now, almost a necessity or as a important thing in every ICU, it will have a bedside USG. Good expertise is required for correct interpretation, and it has got some role in differentiating between a pleural loculation and a superficial lung abscess. A very important advantage or advance in particular ultrasonography is a new advance called as EBUS, that is endobronchial ultrasound. It is a minimally invasive application, highly useful in accurate evaluation of mediastinal lymphadenopathy and also important for needle aspiration biopsy in chronic lymphadenopathy like sarcoidosis. CT scan thorax is superior to conventional X-ray due to its cross-sectional perspective. It can scan the entire organ in single breath. High resolution image can be obtained by spatial reconstruction like a multi-slice CT. Contrast enhanced HRCT is useful in distinguishing blood vessels from other structures. So CT scan obviously is the investigation of choice when X-ray is not useful. Indications are persistent pulmonary symptoms with a normal X-ray, congenital structural lung diseases to distinguish between a pleural loculation and a lung abscess, interstitial lung diseases, detection of early bronchiectasis, identification of parenchymal disease with pleural pathology, mediastinal masses. CT angio is useful in pulmonary sequestration cases and sometimes for guiding in percutaneous drainage of a large superficial lung abscess. MRI is another advanced important radiology imaging modality. It will assess both structural and functional aspects in single imaging study. The advantage is, of course, no ionizing radiation exposure, delineating hilar and vascular anatomy. It is mainly used in newborns with associated congenital heart disease and for arch anomalies. Can you please request them to mute? But remember, lung is the most difficult organ to image by MRI study. So it's relatively difficult. Now coming to lab investigations, there are a few lab investigations which can be valid in chronic cough. Serology can be of use when you have an IgG antibody titer rising by 4 folds, particularly for a mycoplasma infection. In rare conditions like invasive aspergillosis, galactomannan assays can be important, which are few serological applications for a chronic cough. Molecular tests are useful for detection by PCR and nucleic acid sequencing. They are useful in detecting various microbes like unusual bacteria, viruses, fungi responsible for chronic pulmonary diseases, and situations like persistent pneumonia, protracted cough, and unusual course. Microarray-based assay, BioFire, which we are now all familiar with, is useful in detecting microbes like Mycoplasma, Bordetella pertussis, Chlamydia, and adenovirus, etc. Extremely valuable test in a critical scenario when the child is not improving, there is a worsening state. BioFire is a very important thing which can give you a diagnosis. Smear microscopy, as we all know, familiar with tuberculosis, acid-fast bacilli detection on ZN stain. CBNAT and Gene Expert, excellent test for smear negative childhood TB cases, also gives information on rifampicin resistance upfront, and MGIT cultures, which yields the mycotuberculosis in shorter period, 2 weeks compared to the suspected. Tuberculin skin test and IGRA are screening tests, but they are mainly for detection of latent TB, and they are not preferred now. As you would know, with any all the NTEP programs now recommend that empirical antitubercular therapy should not be started. There should be at least an attempt made to at least demonstrate physically, either by microscopy or by gene expert study, the presence of mycobacteria before you start the treatment protocol. Coming to the second league of investigations, pulmonary function test. This has been elaborately discussed by Dr. Barnali, Dr. Sanjay. Spirometry is a gold standard test for assessment of lung and function. It is portable, it is relatively inexpensive, most preferred, can be easily done in children more than 6 years of age. Now, the GINA guidelines recommend it as a mandatory test to diagnose asthma in older children, and it is even recommended to be done before starting the therapy. It is used for both the obstructive as well as obstructive lung diseases, and it is used for diagnosis as well as for monitoring purpose. In younger children also, it can be done in some special labs. Spirometry principally measures the forced vital capacity, FVC, a combination of tidal volume, expiratory reserve volume, and expiratory reserve volume, except the residual volume. Now, the forced vital capacity is the most important to be monitored. You have newer spirometers which utilize the computer technology which generates varieties of values, percentage. So it is now becoming a more easy, you have good softwares which are available for assessment, and that's why you get good readings, reliable readings for spirometry. The predicted values are obtained from studies on normal subjects, and standing height is considered as a predictor. These are some standard spirometry reports. Now, what is the role of spirometry in asthma diagnosis? All older children more than 6 years suspected to have asthma are recommended to undergo spirometry upfront. Normally, the FVC is more than 0.9 in children. In asthma, FEV1 to FVC ratio is reduced, less than 0.9, which confirms obstruction and the airflow limitation. In addition, the child is made to exercise for 10 minutes and a repeat spirometry is done. If the FEV1 is less than 10% further, it confirms exercise-induced airway limitation. Bronchodilator reversibility test is done later by inhalation of salbutamol 100 micrograms, 4 separate puffs through MDI and spacer, followed by a repeat spirometry after 10 minutes. If the FEV1 levels improve by more than 12%, it indicates reversible bronchoconstriction and confirms the diagnosis of uncontrolled asthma. So this is how one makes an assessment of asthma diagnosis in spirometry. This is the report, as you can see here. This is before bronchodilator. This is after bronchodilator. Of course, this is the normal curve. Other pulmonary function tests of use are peak flow monitoring. Peak flow meters are portable, inexpensive devices. They are mainly used for long-term monitoring in an asthmatic child. There are marked variations from baseline values that suggest inadequate control of asthma. Also, a regular PFR monitoring can detect an acute flare-up episode early. So definitely a very useful tool, but mainly for monitoring purpose. Impulse oscillometry, a very exciting prospect, particularly for children who have airflow obstruction in a younger infant where spirometry is not feasible. In this, the principle is that sound waves are superimposed over the patient's airflow and the obstruction in the large and small airways assessed. A very exciting test, probably we'll have more to have seen in the near future. Now coming to invasive investigations which are required for a chronic cough, by far the most important amongst them is flexible bronchoscopy. It is an indispensable tool in diagnostic workup of respiratory diseases. Newer advances have made bronchoscopy a very safe procedure. Flexible bronchoscope has many advantages over the traditional rigid bronchoscope, and it is like a flexible rope-like instrument which can negotiate through apertures. It is generally introduced through one of the nostrils and even can visualize the upper lobe. It is generally done under local anesthesia. So it's a OPD procedure. Of course, you require an anesthetic backup and a good critical care unit to follow. So it is to be done in a setup where you have all these facilities available. What are the indications of bronchoscopy? Congenital anomalies presenting as noisy breathing or persistent rather, as Dr. Rajesh showed in that audio, persistent or recurrent pneumonia, a missed foreign body aspiration, segmental lesions as you would see in endobronchial tuberculosis. Sometimes you would do a bronchoscopy for doing a bronchoalveolar lavage or for microbiological evaluation. Someone made a mention about the diagnosis of persistent bacterial bronchitis. Sometimes a BAL lavage is also indicated here. Persistent unresponsive wheezing is also an indication. One would probably think of doing a bronchoscopy, and of course for endobronchial toilet in these rare cases. Now I'll just make a mention about one important situation which comes with chronic cough, cystic fibrosis. It's a chronic life-limiting genetically determined disease. Chronic bronchial infection and inflammation with pansinusitis is a common presentation. Sweat chloride test is already been mentioned, an important screening tool. Levels of more than 60 millimoles in children and more than 30 millimoles in infants are strongly suggestive of cystic fibrosis. 2 test results are done on separate days to confirm the suspicion. Genetic studies are confirmatory. CFTR gene, which is located on the long arm of chromosome 7, a mutation found in this CFTR gene is diagnostic of CF. And other supportive evidence, of course, is a microbiological isolation of Pseudomonas or Staphylococci in the cultures of tendon and bowel samples. These 2 bacterial infections are more commonly seen with cystic fibrosis. Protracted bacterial, I think I will not go into that because Dr. Rajesh has already discussed this. Immunodeficiency can present as recurrent infection or persistent pneumonia, and various studies are required for this. Bronchiectasis, of course, this is also discussed. In chronic cases presenting with respiratory distress, tests are generally done to evaluate the pulmonary function test. Aspiration syndrome and GRD, they come with recurrent cough in infants related to feeding and vomiting. In case of failed trial with the proton pump inhibitors, esophageal pH monitoring and Mills scans are required. Coming to chronic dry cough, just a mention, in children having normal growth parameters with no associated red flag features, it is quite common. Upper airway cough syndrome is being dealt by Dr. Rajesh, so I'll not go into that. Associated allergic rhinitis, other markers are often found. So one must always rule out, as Dr. Dipti mentioned in her talk about the need of association between allergic rhinitis and asthma is often seen in more than 80% of patients. And it is, as she mentioned, what we call now as a unified airway problem. Somatic cough syndrome, again discussed by Dr. Rajesh, so I'll not go into that. So the take-home message is, investigating a child with chronic cough is influenced by a good history and examination. Chronic dry cough is in an upper airway cough syndrome, and somatic cough usually do not require any investigations. Chest X-ray by far is the most common investigation. An abnormal X-ray is highly specific for an underlying cause but carries poor sensitivity. HRCT is an useful tool for diagnosing unresponsive cases. Lab investigations have a significant role in diagnosis of superiority lung disease and tuberculosis. Ultrasound studies have emerging roles, as in EBUS, what we discussed. Spirometry is an invaluable tool to assess pulmonary function and is recommended in all older children with suspected asthma. Flexible bronchoscopy is indicated for diagnostic as well as therapeutic purpose and is an immensely useful diagnostic modality. Molecular studies have an important role in TB diagnosis. Special tests like sweat chloride and genetic studies are diagnostic for cystic fibrosis. Therapeutic trials are often advised in certain conditions like persistent bacterial bronchitis and GRD before we investigate further in unresponsive cases. And advanced tests are advised in suspect disorders like immotile ciliary syndrome and immunodeficiency disorders. Thank you.
So there is one question regarding misuse of cough syrups. So can you address that?
It's a very contentious issue. And I think, as we mentioned earlier, cough syrups have a limited role in chronic cough. In fact, there are very few preparations which have any definite role. As we made a mention about some therapeutic options, like for example, giving a trial of 2 weeks of amoxiclav in a suspected protracted bacterial bronchitis, or giving a trial of proton pump inhibitor for 6 weeks for a child suspected of GRD. There are no specific therapies available for treating chronic cough. So rather than giving a medication for chronic cough, it is always better to go for the root cause, but reassure the parents, try to identify the cause. And if it falls in the category of something like what you can say, a habit cough or something, then you just require to do a little bit of reassurance. But generally, we don't recommend any cough suppressant for a treatment of chronic cough. Mucolytics, bronchodilators, Dr. Sanjay mentioned about in that slide, a child, how he got irritable after taking oral salbutamol. So all these have, they have a lot of limitations, a lot of side effect profile. So I think as a whole, a treatment for cough syrups are not the option for treating cough. You should be addressing the cause behind it. And that's the most important take-home message.
Thank you, sir. Thank you very
Be it a bronchodilator, be it an expectorant, you must explain to them for what purpose you are prescribing it. Otherwise, you know, so many times we see that the parents come, they switch pediatricians, they carry prescriptions, and more often than not, they don't even know what they're giving. So I think the key to success, as Dr. Pramod Jog has rightly mentioned, the key to success is proper interrogation. Spend time. In our asthma training model, there is a very important line. They say that don't just give the prescription, give time to the patient. So then only you will get better results to the problems like chronic cough or asthma like that. Thank you.
Thank you, sir. Thank you. Such a nice talk. And thank you for ending this session with such a nice talk. Now, at the end of this session, I thank you all the speakers, Dr. Aarti Kinikar Madam, Dr. Barnali Bhattacharya Madam, Dr. Deepti Pujari Madam, Dr. Sanjay Nathu Sir, Dr. Rajesh Kulkarni Sir, and Dr. Jayan Joshi Sir for accepting our invitation and giving these nice, in short, talks. I know you had very big presentations in the Pedicon, but we requested you to cut down it to 10 minutes. So thank you very much for accepting our this request and during these talks.
Thank you very much. Really appreciate the initiative on behalf of all my co-panelists, Dr. Barnali for a brilliant idea, and for Dr. Shirish, Dr. Keyur for taking it forward. And it's a very, very good idea. It should be carried out every year. And it was a privilege to be a part of this session. Thank you so much.
Thank you, sir. There will be a second webinar for the remaining speakers. Mostly non-respiratory topics will be covered. That will be conducted on 22nd of March, next week on Friday. And also we have a hematology workshop coming up on 31st March, the registration for which is going on. So I request all the participants to register in high numbers for the hematology workshop. So thus now I hereby declare this meeting to be ended. Thank you. Thank you very much.
Thank you.
Thank you, sir.
Thank you. Thank you.
Thank you.